Cardiac output is stroke volume multiplied by heart rate. It's an amount of blood that circulates in 1 minute, okay? Liters per minute. We'll get into a lot more in a little bit more today on why does stroke volume change, why does heart rate change, how do the combination of those two things affect cardiac output, which one is more important during exercise, et cetera, et cetera. Some numbers, and I do want you guys to have a general sense of these numbers, okay? At rest, cardiac output is roughly 4 to 6 or 7 liters per minute. It's mostly based upon heart size, which is based upon blood volume, okay? So smaller individuals have smaller blood volumes. They tend to have smaller hearts. They have smaller cardiac output. So normal is somewhere, in and around 5, okay? During maximal exercise, when you increase cardiac output as much as you can increase it, 4 or 5 times. So if you're a 5 liters per minute person, you may be able to get it up to say 20 to 25 liters per minute. So the blood is moving much, much faster. You're moving much more blood through the heart, okay, in a minute. In elite athletes, they may sometimes have resting cardiac outputs of 7 or 8 liters per minute. So their max is going to be somewhere around maybe the mid to high 30s. Okay. Most of you are going to be in a place where you can increase it about 4 to 5 times from rest to maximal exercise. Okay. So that's kind of what we're looking at. Okay. This will matter when I show you guys how we take the numbers from cardiac output and we can try to convert that into an actual oxygen consumption number. Okay. Okay. So we're now going to talk a little bit about some really important factors that you guys, I think, have heard of before. Okay. But is how do we regulate both heart rate and stroke volume? We've covered some of the heart rate stuff with epinephrine and norepinephrine and input to the SA node and those things. But if we want to look at stroke volume, okay, why does someone have a larger stroke volume than someone else? And then why, when we begin to exercise, does stroke volume increase? One of the kind of very, very key parts of this is something called preload, okay? Preload. In essence, preload is end diastolic volume. In diastolic volume. So if I get more blood into the left ventricle, okay, before we reach systole, that will drive an increase in how much blood gets ejected from the heart. Okay, this graph on the right, the x-axis is ventricular end diastolic volume. So this is here is preload. Okay. As end diastolic volume goes up, you're going to see what they're calling ventricular performance, okay? This can be a measure of contraction strength. It can also just be, we're going to call performance how much blood leaves the ventricle. So it's actually sort of in ventricular end diastolic volume graphed against actual stroke volume, okay? And what you will note is that as end diastolic volume goes up, stroke volume goes up, or ventricular performance is going to go up to a point, okay, to a point. This is based upon things we've already talked about, okay, things that we've already talked about. You guys have probably heard of something either in anatomy or physics called the Frank-Starling mechanism or the Frank-Starling law of the heart, okay? All the Frank-Starling mechanism is a counter movement jump, but it happens in the heart, okay? All that it is sink and stretch before I jump, okay? And so what that tells us then is as end diastolic volume increases, as we force more and more blood into the ventricle expands and it stretches, okay? It stretches. Just like doing an eccentric contraction before doing a concentric one. Just like sink down and then jump up, okay? So when we increase preload, more stretch, Therefore, we're going to get contraction force from the actin and myosin in the cardiac muscle, plus some additional elastic kind of rebound from the connective tissue, just like we do in a normal skeletal muscle contraction. Okay. Does that make sense? Okay. Now, this is going to plateau. You can only put so much blood in the left ventricle. It's only so big. It can only stretch so much, right? So at some point, there's no more of that we can get. Okay. So there are limits on preload. There's limits on preload. But this is one of the things that happens. And we'll talk about how exercise alters preload or other things do a little bit later on. Okay. So we have talked a little bit about a couple of these. Okay. So I'm going to talk about a couple of the others. So here's some other factors that are going to affect preload. This is just how we get more blood into the left ventricle. Okay. Two of the biggest ways that we increase stroke volume is by increasing cardiac output and increasing something called venous return. And so a lot of these other things here are going to relate to how we get more cardiac output and we get more venous return. Okay. Anybody ever run a race and they tell you to walk or jog a little bit at the end, not just go dead on, full stop? Yeah. Why do you do that?
Usually we want to be one of the things they tell us way like lactate, they make flush like so.
Sure, you are flushing lactate, but the bigger issue is someone can pass out, right? Anybody ever done that? Like you go stop and you feel faint? You go over. Am I the only one that's ever done that?
Not right.
No?
I was running during the football camp and I passed out while running.
Okay, I mean that also works. All right. So if we get and we force more blood back into the heart, we're going to end up getting more into the left ventricle. That's called venous return. Okay. And so one of the ways that we increase venous return is through muscle contraction. All right, muscle contractions, which is going to be this muscle and thoracic pump. Right. You have veins in your arm. You do a bicep curl like so, and the muscle squeezes those veins and it forces blood back towards the heart. When you're running or you're walking or you're squatting or whatever you're doing, you squeeze the veins in those muscles and veins have kind of one-way flow because of valves and it forces blood back. Okay. Also, if you increase cardiac output, you increase what's leaving the heart, then that's also going to sort of force and push more back in. So that's one of the big things. One of the other ways that we increase cardiac output and venous return and therefore can increase stroke volume is by increasing blood volume. If you have more blood, there's more that can get sent into the left ventricle. I know that's kind of a weird thing. Okay. But that's one of the big adaptations to aerobic training is that you increase your blood volume by about 1 liter or thereabouts. Okay. Posture affects venous return. When it had first aid, somebody gets lightheaded, they pass out. What are we supposed to do? Right? Check their airway, get them over onto their side of the back, get their feet up. Okay. We're going to use gravity then to help us get blood back to the heart. Okay. On those things. You guys never know when you have to use that. I had a student that passed out on our very first day of class, like 6 or 7 years ago. And she told me, like, Dr. Black, I'm about to pass out. She had sort of autonomic dysregulation, and this happened a lot. Just the very first day of class. And luckily, someone that she'd gone to high school with that knew her for forever, knew that this happened, was right there. We just got the class out, we got her down, got her feet up, she was fine. Popped up, here we go. Okay. So posture matters. Posture matters. Heart size, the other thing that really matters. Okay. If you have a bigger heart, anatomically, okay, a bigger heart, a larger left ventricle. Therefore, you can put more blood in. Okay. Heart size is generally related to body size and state of aerobic training. But one of the big adaptations to aerobic training to make stroke volume go up and therefore cardiac output Because your heart gets bigger and your blood volume gets bigger, so we can have greater cardiac output and venous return, and we have a larger left ventricle as well. Okay, so that's kind of how we're gonna try to regulate these things. But preload is one of the big things. Okay, preload is a very, very big sort of part of regulating stroke volume. Okay, so we talk about this. This is pretty straightforward, right? On the right, you guys can see a vein. You can see that vein running in between some muscles. Veins have valves in them, and they prevent backward flow of blood. So once you get blood to a certain point in the veins, and then you contract the muscle, it squeezes up, forces it forward. It can't go backwards because of the valves. That's called the muscle pump. Okay. We also get some sort of suction or pulling of blood forward from what we call the thoracic pump or breathing. Everybody take one big deep breath in. Ready? Let it out. As you breathe in, okay, we open up and expand the volume in the chest cavity. That lowers the pressure in there. That's why air rushes in. But it also lowers the pressure that blood in the venous system has to work against to get back to the heart. Okay. And that creates this kind of sucking action. So breathing in very deeply helps to pull blood back towards the heart as well. Both of these two things go up significantly when we exercise. Lots of muscle contractions, so lots of muscle pump, lots of sort of increases and deeper breathing is going to keep thoracic pressure down to an extent, both of which are going to aid with venous return, which is going to make stroke volume go up. Okay. Another piece of this on stroke volume regulation is something called afterload. Afterload is how much is basically in systolic volume, how much blood is left in the ventricle at the end. Okay. This is very much related to things like blood pressure or like aortic blood pressure. Okay. If I raise aortic blood pressure, it's more difficult for the blood to get out of the ventricle. So less will go out. Okay. So when we increase afterload, the heart has to do more work. It's more difficult. It has to contract more forcefully. Okay. One of the things that leads to increased afterloads tends to be resistance training. Okay. When you resistance train, you do something called the Valsalva maneuver. You guys have all heard of Valsalva before? Okay. You contract your diaphragm, right? You contract your abdominal muscles. And the point of doing Valsalva is to raise the pressure inside sort of the thoracic space here so that when you generate high levels of force elsewhere, you don't squish your internal organs. Okay. You hold your breath, you Valsalva, blood pressure can go up to like 500 over 300. It's wildly high. Okay. Because of that, then aortic pressure is really, really, really high. And so it becomes much more difficult. The heart has to contract much more forcefully in order to get blood to move from the left ventricle and overcome that very high aortic pressure. Okay. So Valsalva is the thing that we encounter, but also you can imagine a scenario whereby if you have hypertension, if at rest, if normally you have higher blood pressure, then aortic pressure is higher. The heart has to work and contract more forces, to work harder every time it beats to generate a sufficient pressure to overcome your elevated aortic pressure to get blood to move out. And over time, that can cause some problems, okay, that we'll talk about. It can cause some problems. So we do see some evidence that people that do lots of resistance training and don't aerobically train, they may be more prone to elevated blood pressure and then stiffening of arteries, which can lead to a greater chance in some instances of cardiac arrest and heart attacks and some of those kinds of things. It's really, really, really tricky though, to kind of draw a link there. So I don't want to ever discourage anyone from resistance training, but there's some kind of tension between some of the adaptations we see there and adaptations that we see with aerobic training. And we kind of this. All right, we'll come back to a little bit more about this, and we'll talk about with adaptations to training something called pressure load cardiac hypertrophy. If you have high blood pressure and the heart has to work harder, it will lead to cardiac hypertrophy. The muscle is going to hypertrophy and get bigger so it can generate more force. But if it's because of things like this, because of high blood pressure, it's actually maladaptive. When you do it the other way, because you force more blood back in, then it's called volume load hypertrophy. It is actually a better deal. We'll get into that when we do aerobic training. Okay. Okay. Let's talk about blood vessels. Okay. Anybody squeamish about blood vessels? Anybody squeamish about blood or anything else? No? I've told y'all that you can just like tap my wife inside of her elbow and she'll pass out. No? Okay. We have to like prep for weeks if she has to go give blood. Right? We had a whole like thing when she was pregnant and we were going to go and she's going to have a bunch of blood drawn so they could do all the genetic testing and things on Ellis and everything. And we did prep for several weeks and kind of get her motivated and all of those kinds of things. So she does not do good. When Truman and his brother Gus were puppies, they knocked the thing off and Truman's tail was bleeding and she was at home with them and I had to come home from work to like wrap his tail up because if she sees blood, she's going down. So it's just the way that her sort of autonomic system is set up. So I say all of that to say, we're going to talk about blood vessels. We're going to talk about blood. There will be some pictures. I may have you guys try to like feel around and do some things. So just do what you need, okay, as you can with this. Okay. 3 big major categories of blood vessels. Arteries, which include kind of large conduit arteries, and then arterioles, which are smaller ones. Capillaries, and then veins, which include large veins and venules. What? Okay. Arteries and arterioles are so named because they carry blood away from the heart. Venules and veins are so named because they bring blood back to the heart. Please remember that while it is almost always true, arteries and veins are not named because of the oxygen content or relative oxygen saturation in the blood that they're carrying. Most of the time, arteries are carrying high O2, high saturated with O2 blood, but not always. Okay. Similarly, veins generally have lower O2 sat, generally lower, but not always. That's what's going to be there. We've talked about veins some. We're going to spend a little bit of time talking about arteries and especially arterioles. Okay. Something unique about arteries and arterioles is that they have muscle that surrounds them. Okay. It's not skeletal muscle. It's not cardiac muscle. It's called smooth muscle or vascular smooth muscle. What this smooth muscle lets, especially arterioles do, is expand and contract. Okay. We call this process vasodilation. Vaso meaning vessel, dilation meaning expand, and then vasoconstrict. Okay, so they can squish down and make themselves more narrow, or they can relax the smooth muscle and they will get wider. We're going to use this process to control where blood goes in your body. Okay, we can shift where the blood is going relatively. Okay. And we do that by constricting and relaxing, mostly arterioles. Arteries will also do the same. For the most part, veins generally don't have a lot of smooth muscle. They don't have a huge capacity to change things. Capillaries don't have any. Capillaries are tiny, 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 tiny vessels, generally only wide enough to fit one red blood cell through at a time. and they're very holy. Okay, they have lots of pores or fenestrations in them that allow for stuff to pass in and out of them very, very easily, which is good because we move the blood around in the arteries and arterioles, we get it next to the tissue in our capillaries, and then we exchange gas and nutrients and hormones and things from the capillaries to the tissues, and we put tissue stuff back into the capillaries, then it gets to the veins, and we come back towards the heart. Okay, all of that stuff should generally be reviewed for you guys, right? Okay, very good, very good. So this is kind of a general kind of look at this. Okay, you can see the heart, you can see our large arteries, you can see them branching off into arterioles, you can see the capillary beds down at the bottom. Then the capillaries run into venules back into the larger veins, and then eventually back into the heart. Okay. Veins have valves, arteries don't. Okay. Arteries have much, much more smooth muscle and a much greater capacity to change their size. We'll get into that in the next few slides here. Okay. Okay. So you can see those sorts of things. We call, as arteries branch out into arterioles and then capillaries, we call this microcirculation. Okay. Microscopic level or tissue level circulation. This is not, right, stroke volume, cardiac output, even flow in the aorta or the interior or superior vena cava. That is kind of systemic, large scale flow. This is what is happening to get blood to individual tissues. Okay. Arterioles and veins and capillaries are a very, very highly branched network. Okay. Lots and lots of branching so that we have lots of ability to provide flow to and from little small individual pieces of a tissue or an organ. Okay. So the key thing to remember, and I'm going to say this word. Now can I ask the word, who's anybody in physics 2? Anybody in physics 2? Okay. 2 of y'all. Okay. If I say resistance, when we talk about resistance to like electrical currents and things, you can throw stuff at me. It's terrible. It's backwards. It's the worst thing in the entire world. Okay? Because it doesn't make any sense. We call arteries and arterioles resistance vessels. Okay. What this means is, okay, resistance is going to denote how easy or difficult it is for blood to pass through those arteries and arterioles. Okay. If I increase resistance to flow or increase resistance to blood moving through a vessel, what that becomes then is it becomes more difficult. Okay. So less blood will move through, that tissue will get less flow. Okay. So we're going to alter, okay, we're going to alter the diameter of especially arterioles to play around with the resistance to flow to certain tissues. Okay. I'll show you guys kind of an electron micrograph of what this stuff is going to look like. And what you guys will see in the next couple of slides is an arteriolar network, where much of this resistance or our ability to constrict or relax and control where blood's going to go comes from. So we have what are called first order or primary arterioles. They branch into second order, branch into third and fourth, and eventually down into these terminal arterioles that eventually become capillaries. You don't have to look at a picture and tell me, is this a first order or a second order or anything else? I just want to expose you guys to that concept. Here we have, right, this is down, which you can see in the very background. Those are actually that skeletal muscle. These are, right, first order arterioles that are going to come from here. They branch into third, into second order, then into third, but they sort of go perpendicular. So one runs this way, and then it branches off like this. And then we branch off of that one like this, and we eventually spread our way out, all the way out until we get to these capillaries that are going to sort of come off of the terminal arterioles down onto the tissues. Okay. trying to think of a good analogy, or at least a humorous analogy. Think of, right, those of you, who's from Dallas, or at least the metro area, okay? My least favorite place to drive ever. This is from a guy that spent 10 years in Georgia and has had to deal with Atlanta traffic, which I thought was the worst thing in the world until he came back. And I'm like, why? Why is it this way? Okay. Why is there always construction? Why? Why? They've been doing construction my entire life. Okay. If we were going to Dallas, traffic is fine on I-35 until where? Most of you guys. Did right about where 35 splits, right? So you get to the crazy green, you get right there to North Texas's campus. Okay. It splits, there's construction, that's resistance. Okay. That's resistance to traffic flow. Okay. If there's a wreck and you've got traffic flow and it's messed up in a large place, then you can try to get around and go off on the side streets and things. That's going to get us this. But so you can imagine blood flow functions the same way. If I squeeze down this first order arterial here, squeeze it down, everything downstream, everything distal to that gets less blood flow. Okay. So one of the ways that I can really affect where blood goes is by squeezing or relaxing those first order arterial. Once I get through there, though, maybe I want blood to this tissue, but I don't want too much, then I can constrict and dilate these sort of third, fourth terminal arterioles that are down much closer right next to the individual tissues. And we'll talk about how we do both of those things in just a bit. Okay? But that's the idea. That's the general idea. Flows like traffic. Although we really know, if you read any books on, my wife has done this because she's obsessed with traffic for some weird reason, that the way to make traffic less of a problem is not to make roads bigger. It's actually to make more smaller roads and more routes to get to someplace. And if you put more lanes on 35, you just get more cars on 35. And you don't actually fix your problem. Or you fix your problem for like a week and then you do other things. Anyway, but that's what's going to happen here. Okay. Okay. So we have talked about the smooth muscle. As it relates to the smooth muscle and our ability to contract and relax, though, we have to cover two other anatomical quirks of arteries and arterioles. The first of those is there's a single layer of cells that lines the inside of arteries and arterioles, and it's called the endothelium. Okay, it's called the endothelium. The endothelium senses something called shear stress. Okay, shear stress. Shear stress is basically the stress or the friction generated by blood as it runs along right under and brushes up against the endothelium. Okay. When blood velocity increases, when flow increases, it increases shear stress. And that causes then the endothelium to release something called nitric oxide, NO. Not laughing gas, not nitrous, but nitric oxide. So the endothelium then uses nitric oxide to communicate with smooth muscle, and it generally tells it to relax and let more blood flow come through, because that widens that vessel, it lowers blood velocity, and that reduces the shear and the stress and so on. Okay? Dysfunctional endothelium, primarily due to atherosclerosis, is one of the single largest causes of cardiovascular disease and therefore death in the modern world. You cover up the endothelium with those fatty plaques, so when blood velocity and things go up, it can't get the signal, and therefore it can't widen, and blood pressure skyrockets, and that can be a real problem. Okay, so this is what's going on. Function of the endothelium is one of the things Dr. Kellogg and his lab study for us. So in addition to the endothelium, the smooth muscle that surrounds arteries and arterioles has a second way to be told to either constrict or relax, and that is by sympathetic nervous system innervation. Okay, you have something called a perivascular plexus. All that is it just means there's a network of little baby nerves that are going to connect from the sympathetic nervous system into the smooth muscle that surrounds your arteries and arterioles. Okay? When epinephrine and norepinephrine is released in response to stress or exercise or whatever it's going to be, that then will tell the smooth muscle to either contract or relax. In a lot of places, it tells it to contract, okay? And then when you're exercising, the sympathetic system tells it to contract, and then the endothelial function is going to actually override some of that. So it's kind of a complicated deal, but that's what's going to happen, okay? Here we have what looks like a Michelin tire man, right? Got our little rings of smooth muscle around our vessel. They dissolve all of that away, and you can see in and coming onto those rings, you can see here is all of those little sympathetic nerves that are going to innervate that. Okay, so we have two ways primarily, two big primary ways of telling arteries and arterioles to either vasoconstrict or vasodilate, okay, to control where blood flow is going to go. All right. Okay, we'll come back to a little bit more of that later on. We good? Do you all need me to make someone get up, and we will change their blood distribution by stimulating either the endothelium or the sympathetic nerves that connect to those things? We can do all of it at the same time. Yeah, people like no. Okay. All right. Well, usually when we do that, right, you get somebody to stand up, we try to embarrass them, right? And the face becomes flushed. That's a sympathetic nervous system response to send blood to your skin because it's fight or flight. It thinks we need to be able to dissipate heat. Okay. In that same response, we vasoconstrict all of our blood vessels going to stomach, liver, those kind of areas, the splenic regions in an effort. We don't need to digest things. We're going to have to run away from a saber-tooth tiger or whatever. Okay. So that's kind of what's going to happen. All right. So we need to talk about blood pressure. And not only sort of where to put blood pressure in this. It's someone who likes to talk about blood pressure first. This is the one thing that drives how blood flows and how it moves. Okay. Blood pressure is, by definition, the pressure exerted on the inside of a blood vessel wall. Okay. When we measure blood pressure, typically in your brachial artery, what we are measuring is how much pressure does the blood have to exert on the inside of my brachial artery in order to force, as the pressure falls in the cuff, to force the brachial artery back open so that flow can continue. Okay, that's what pressure is. We usually express it as arterial pressure, but we can find arteriolar pressure, we can find venous pressure if we want to. And we usually express it as two numbers. This number over this number. What that represents is a systolic pressure, or the pressure of the blood exerting on those walls during the contraction of the left ventricle, and then a diastolic pressure, or the pressure exerted during left ventricular relaxation. Okay? Systolic over diastolic. Highest pressure typically while there's an active contraction forcing the blood out. That will raise pressure. It relaxes. That tends to be the lowest pressure that occurs during the filling. We don't use this nearly as much anymore. Things kind of come into and out of style in the cardiovascular world. But we used to talk about, when I was a student, something called mean arterial pressure. And this is a way to try to account for the average pressure that a vessel is exposed to over the whole sort of one heartbeat or one cardiac cycle. And at rest, it's generally, right, 1/3 systolic pressure, 2/3 diastolic pressure. Higher mean arterial pressures are associated with hypertension. They're associated with more stress in the cardiovascular system. Mean arterial pressure also goes up a bunch during exercise, but at rest, higher mean arterial pressure does that. In a lot of instances, elevated diastolic pressure is more dangerous than elevated systolic pressure, for kind of a host of reasons. Okay, that's what we've got. So that's how we're gonna talk about blood pressure. Pressure falls across the vascular system. Okay, the highest pressures are going to be inside the ventricles. So inside the left ventricle, very, very high pressure. Next highest pressure is in the aorta. Then as we move through arteries, pressure is higher. We move down from arteries to arterioles to capillaries, pressure falls. We move into the veins, it falls further. And then the lowest pressure is going to tend to be back into the right atrium. The system is set up this way because it's not like this. Blood doesn't move. Blood moves or fluids move from high to low pressure. High to low. So it's got to be highest at the start and lowest at the end, or it will not move. Okay. It's very easy, I think, to demonstrate. All I want you guys to do, this is where I'm like, are you squeamish or not? Everybody squeeze right here over your brachial artery, okay, like this. When I squeeze, I raise the pressure there, and I collapse the artery. And if I do that, there will be an immediate response of an increase in cardiac output here to try to raise the pressure to get it through. But if you squeeze enough, pressure is too high, blood can't get through, so it doesn't go there. Okay, you can cut off flow to certain areas because somewhere downstream has a higher pressure than what the arterial system can expose it to, and so flow will not go anymore. This is what happens when you get blood clots. Okay, is it will cut off flow in this particular way. So high to low. So I'll ask this particular question: if I want to make blood move more, okay. If I want to make it move more, if I want to make it move faster, what should I do to blood pressure? It says down. Thinking about it. Anybody else? What do you think? How am I going to get more blood or more flow into, say, my calf muscle to do calf raises? I really have two options. So what are my two options? Increase heart rate. Okay, we can make cardiac output go up, but if from a pressure standpoint, what are my two options? I'm sorry, you said decrease pressure of something.
And the place you want it to go.
Decrease pressure in the place I want it to go. Good. And or what? If I don't decrease the pressure where I want it to go, I can increase something else, and that might achieve the same thing. Can it be anywhere else, Elder Grace, or should it be, is there a very specific place? At the start. Good. Okay. So if I want more flow into the capillaries and skeletal muscle, I need to either raise pressure on the front end, so the difference in pressure from left ventricle to the capillaries in those tissue is larger, or I can lower and drop the pressure down here. Okay. Now, what we normally do is two things. We vasodilate in the arterioles that are going to go to that tissue. So we drop this pressure at the specific tissue where I want there to be more blood. And then I increase cardiac output. I increase left ventricular contraction strength. So I raise blood pressure here. So we do both. This goes up. This part goes down. The difference gets bigger. More flow. More blood goes to that area. Okay. So based upon that, what do you guys think happens to blood pressure as you start to exercise? It goes up a lot. Okay, systolic pressure goes up a lot. Okay, more driving, we call that driving pressure. There's more pressure to drive it to those areas, okay? That's the importance of blood pressure. All right, now let's talk about where the blood is in your body. Where is your blood right now?
In our like metabolic organ.
In our metabolic organ. So it's all going to skeletal muscle?
Up. Like
Or I can convince y'all of anything.
almost kind of.
Bernie's right, it's here. My question is this really a metabolic organ? Is skeletal muscle your biggest metabolic organ? Mine's blood. Okay. Who ate breakfast? Like 2 of y'all?
We come here at 8 o'clock in the morning. That doesn't exactly leave us much time to like.
Sure it does. Get up earlier.
I do, and then I run 2 different miles.
Again, get up earlier. Don't run so far. Okay.
That's not even.
At rest, about half or 60% of the blood in your body is here. Okay? Liver, spleen, stomach, intestines. We call that the splenic region, kidneys. Okay? It's right in here in the middle. Okay? We're doing housekeeping kind of things. The brain has a constant amount, the heart gets a constant amount, skeletal muscle gets some kind of relatively smaller percentage. Okay? Mostly liver, kidneys, we're cleaning the blood, we're filtering the blood, right? The stomach and intestine gets some, skeletal muscle gets about 15% of all of the blood. What happens with exercise? It all goes to skeletal muscle. Okay? The brain keeps its portion. So the amount that goes to the heart goes up a little bit because it needs it to continue to function. Basically, everything else can go to skeletal muscle. Okay. So it becomes like 85% of the blood is going to be directed to the actively contracting skeletal muscle. When you combine where it goes with that sort of 5 or 6-fold increase in cardiac output, we can increase the amount of blood that ends up going to or being shown to skeletal muscle during exercise by about 25 times over rest. Okay? We have this unbelievable capacity during exercise to direct a huge amount of highly oxygenated blood to the working skeletal muscle. Blood that has lots of oxygen, glucose, free fatty acids, and the hormones that we need. Okay? We're really, really, really good at changing where it's going to go. When you eat, it goes to the digestive system. This is why they say don't eat and then get in the swimming pool. You eat, it goes to the digestive system, you jump in the swimming pool, you immediately send it all back out to the skeletal muscle, and you're stuck with undigested food in your digestive system. And that's why you get a tummy. Okay. So, heat stress, we move the blood to the skin, okay, to help us dissipate heat as well. Where we get into problems is that during high intensity exercise, when it's very, very hot, is there becomes a competition for blood flow between the skin and skeletal muscle. Okay? Skeletal muscle wins. Or if you're motivated enough, skeletal muscle will always win. And that is why heat stress and heat exhaustion and heat strokes can happen, is because if you need to, if you're really motivated, you will begin to, when it's hot out, and if the intensity is high enough, you will sacrifice blood flow to the skin to send it to skeletal muscle, and therefore sacrifice an ability to dissipate heat, and you can overheat and cause heat exhaustion and heat strokes. It can be really, really dangerous. Okay. Of all of the things that we have, that's the one there's kind of no fail safe for. Okay. This is a cartoon picture showing basically what we just talked about. Okay. You have the rest on the bottom. We have high intensity exercise on the top, and it will show you, right, roughly sort of what's happening with your 25 liters of cardiac output. Okay, there's probably about 5 liters of cardiac output down here. And so what you can see though, the relative size of the organs on here is going to show you kind of where and in what instances it's going to get a certain amount. Okay, so what the big thing to take away though is at rest, liver, digestive system, okay, kidneys, skin, they're gonna get a certain amount during exercise. Parts that get a lot at rest are gonna fall. The heart keeps what it has, everything else goes to skeletal muscle. Heart and brain are constant, everything else goes to skeletal muscle. Okay. That's how we're gonna distribute blood and help ourselves to exercise. Okay, we've talked about how we control blood distribution. We've talked about that there is smooth muscle. We've talked about that it can respond to sympathetic and parasympathetic, or really just sympathetic signals and signals from the endothelium. Okay. So how wide is changing the diameter lead to more or less flow? We'll do some math, and I'm sorry for this math. Okay. So there are several laws. I would always love for there to be like a law named after me in some ways, right? So we have Ohm's law, which tells us that flow, this is for air or fluid, flow is equal to the change in pressure divided by the resistance to that flow. So difference in pressure from one end of the tube to the other divided by resistance, okay? That's flow. Poiseuille's law describes the denominator of Ohm's law. So it describes the things that contribute to resistance, okay? Resistance is equal to, according to Poiseuille's law, 8 multiplied by a sort of the letter N, which stands for the viscosity of the fluid or the viscosity of the gas, okay? Viscosity is kind of how thick, basically, is things. L here denotes the length of the vessel or the length of the tube. Pi, you guys know what pi is, right? 3.14 something, 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 something.
There's so many numbers that you.
Yeah, pi multiplied by the radius of a vessel to the 4th power. In your blood vessels, their length does not change. It is constant. The viscosity of your blood changes a little bit, but not very much. So in essence, the numerator of Poiseuille's law is constant. Pi is a constant. So the only thing that changes according to Poiseuille's law that controls resistance is the radius of our vessel. And it's the radius to the 4th power. So what does that mean? If I change the radius just a little bit, because it's to the 4th power, what's going to happen?
Because it's bigger. Yeah.
It becomes much, much, much bigger. Okay. So the primary thing that controls resistance to blood flow is the diameter or the radius of the vessel we're trying to move the blood through. Okay. Tiny, small changes in vessel radius, or therefore vessel diameter, have very, very large, very significant effects on the resistance to flow. So I don't have to constrict or relax very much to have a profound effect on the resistance term in Ohm's law and therefore flow. So then Poiseuille has two things. We have Poiseuille's law, Poiseuille's equation, where we in essence substitute the things here for the resistance term in Ohm's law. So flow is equal to the difference in pressure multiplied by pi, multiplied by radius to the 4th, divided by 8, multiplied by the length, multiplied by viscosity. Okay. So changes in pressure, primarily systolic blood pressure, and changes in vessel diameter are the primary ways that we control or we alter blood flow. Okay. So if I want more flow to go to a certain tissue, I can raise systolic blood pressure, that helps. And then I change the diameter of the vessels that are either leading to or leading to other tissues, primarily leading to the tissue where I want the flow to go. So it looks like things like this, right? Here's a wrestling vessel, here's a vasoconstricted arteriole, here's a vasodilated arteriole on the bottom. When I make the arteriole bigger, flow through that arteriole goes up dramatically. When I squish it down and I constrict it, flow through there falls dramatically. And that is how we control where flow goes. Okay. So if I want more flow to go to muscle, I need to dilate the arterioles and the arteries that lead to that muscle. If I want flow to go away from stomach, liver, kidneys, and things during exercise, I need to vasoconstrict the arterioles that send blood to those particular tissues. And so we do that through a process called autoregulation and a process called extrinsic neural control. Autoregulation denotes the fact that changes locally in a particular tissue, in this instance, think skeletal muscle, okay? Things happening in skeletal muscle in response to a muscle contraction will send signals to the smooth muscle of the arterioles that are bringing blood to that muscle, and it will tell it to relax. Okay. That's the primary way that autoregulation works. Increase oxygen demand, okay, lactic acid, hydrogen accumulation, potassium, all of these local signals that are likely to be generated in skeletal muscle during contractions will signal to those arterioles that go to skeletal muscle and vasodilate. Bring more flow in, right? So that because we're doing things in that muscle. Additionally, as we begin to send stuff there, as cardiac output and pressure begin to increase systemically, the velocity of blood moving through goes up. That stimulates shear stress on the endothelium. You release nitric oxide, and that leads to further vasodilation. Okay, this is local control. So we're just going to get vasodilation in tissues that are actively doing things. It will have no effect in tissues where we're not doing it. Extrinsic neural control is output from the sympathetic nervous system telling those arterioles to either contract or relax. Okay. So epinephrine and norepinephrine are going to signal and they bind to primarily either alpha receptors or what we call beta 2 receptors, okay, that are going to be contained on smooth muscle in the arterioles. Interestingly, okay, different tissues have different densities or amounts of these alpha and beta 2 receptors. So if epinephrine, when it binds to a beta 2 receptor, causes dilation, okay, tissues that have more beta 2 receptors than alpha receptors are going to get more blood flow when we activate the sympathetic nervous system. Think of your skin, okay? Places that have more alpha receptors, kidneys, liver, stomach, okay? When you get a sympathetic nervous system response, they're going to get more vasoconstriction. When we exercise, epi and norepi increase. And so we send one signal, but we get a differential response based upon our receptor density and our effector tissue. Okay. So more alpha receptors in tissues that don't need blood during exercise, more beta 2 receptors in tissues that do need blood flow during exercise. It's not quite that simple and straightforward. Dr. Kellowan would definitely want me to tell you guys that. But for our purposes, that's sort of roughly kind of what's happening. Okay? So I can use one signal, but get divergent responses in different tissues. That's going to be a positive thing. So that's autoregulation or local control leading to more flow, especially to skeletal muscle, and then neural control that's going to cause this differential response and sort of shunt it away from central regions and send it to our skin and skeletal muscle. Okay. All right, we will, on Monday, we'll cover blood, And we'll cover cardiovascular responses to exercise. And then maybe we can do a little bit of review or something tomorrow. Okay? Be on the lookout for the quiz, be on the lookout for the potential short answer question. All right, have a good weekend, guys. Right now, go off of the outlines, I'll see if I can bring myself to write some different things. All about time, all about time.
I was just curious.
I know. Okay.